about is carpal tunnel syndrome ultrasound diagnosis. We will try to keep it short. Hello.
Yeah. बस यार आए उधर से ना फोटो यार आए
Now, what is carpal tunnel? Carpal tunnel is a compact space in the palm of hand from where median nerve traverses. Now, if we see the proximal end of the carpal tunnel is distal palmar crease, and the distal end of the carpal tunnel somewhere ends when the line is extended from the first metacarpal. So, this yellow region is carpal tunnel. Now, why carpal tunnel is famous? Carpal tunnel is famous because median nerve traverses through it, and since it is a compact space, many a times or very commonly the nerve gets trapped between the tendons because many tendons also pass through the carpal tunnel. Now, first, this is a CT image of wrist in which we can see scaphoid and pisiform bone, and we can all feel scaphoid and pisiform bone the out markings, and the distal palmar keys. If we press our fingers, we can easily feel scaphoid and pisiform bone, which is the entrance of carpal tunnel. Now, as we can see, it is an MRI image, and we can see that this dark area surrounded by bones and red band is carpal tunnel. We can see that there are many things, many tendons, flexor digitorum superficialis and flexor digitorum profundus tendons passing through this compact space, along with flexor pollicis longus. So there are 9 tendons in total, and in this picture it is the tendons appear thin, but if we see on USG, we will see that tendons are thick and median nerve also passes through it. So the space is very compact for the median nerve. Here also we can appreciate these are the carpal bones. The blue color is the tendons, and there is yellow color median nerve. Now the median nerve passes through carpal tunnel, a narrow fibro-osseous canal formed by carpal bones and the flexor retinaculum. Increased pressure within this confined space compresses the nerve, causing ischemia and mechanical injury. How? Now suppose we are first of all watching a normal case. In normal case, the yellow line is median nerve, and which is covered by transverse carpal ligament or flexor retinaculum. Now, what is the pathophysiology? In pathophysiology, which is very at times idiopathic, that there is somehow impaired venous flow in the nerve itself, which with time causes neural edema, which means the nerve becomes slightly thickened. Then, if neural edema persists chronically, it gradually develops to ischemia, and then ultimately internal fibrosis sets in, which is irreversible situation. This means that nerve is now getting fibrosis. So slowly myelin sheath and axonal degeneration occurs, and at last there are signs of motor impairment also. So carpal tunnel starts with tingling, pain and paresthesia in the first 3 phalanx, and then gradually it progresses to motor impairment, where the person loses his grip power. So as we can see here, this is idiopathic, in which we do not know why the median nerve is showing signs of carpal tunnel, and the most common theory is that the volume of carpal tunnel decreases, hence median nerve gets compressed. In the secondary situation, we will find that there is a secondary cause, like there can be a lipoma, there can be a ganglion or accessory muscle which reduces the volume of carpal tunnel and hence causes compression of the median nerve. So as we can see, pain and paresthesia in the thumb, index finger and medial finger. And hallmark feature is patient awakens in the night due to pain in the palm, in the thumb and index finger. Now gradually it leads to reduced grip and gradually in the advanced stage there is thenar muscle atrophy. Now this is the first USG image of median nerve. Now here we can see that the appearance of median nerve is of honeycomb appearance. Why? Because this blue shaped round figure is fascicle, which is echogenic in median nerve, and the perineum, the yellow shaped sheath that is covering all the fascicle, is perineum. So perineum is dark, that is hypoechoic, and fascicle is hyperechoic. So it gives median nerve its classical honeycomb appearance. If there is honeycomb appearance, we can see that it is a healthy nerve. And the echogenic area surrounding the median nerve is epineuron, which is always bright. So technically median nerve is like all the nerves, median nerve is hypoechoic with honeycomb appearance surrounded by echogenic epineuron. Now in carpal tunnel what happens, like I am showing you these two images. Now all this dark portion are tendons, and if we toggle our probe it becomes echogenic. Okay, so this is how we differentiate nerve from tendons, that on toggling probe it becomes hypo, hyper, hypo, hyper, but nerve remains hypo or dark. This is longitudinal section of median nerve, and we can see there are alternate white and dark bands signaling that this is a healthy nerve. Now this is first image of carpal tunnel. This is first image of carpal tunnel, in which we can see the scaphoid bone and pisiform bone, and this single image is the most important image for ultrasound diagnosis of carpal tunnel because it shows the landmark scaphoid and pisiform, which is very easy to locate in ultrasound. It showcases tendons which are bright in this image, and it showcases this hypoechoic structure or dark structure which is median nerve, and all we have to do is take area of the median nerve. Now this is the forearm image where this muscle is superficialis, this muscle is profundus, and between these muscles median nerve is traversing, and we have to take area of this image. So here we are going through some videos to determine how to see median nerve. This is scaphoid bone. This is pisiform bone. Pisiform, scaphoid. Okay. And now this is median nerve. How did we identify median nerve? Because if I toggle my probe, all the tendons become dark, but median nerve stays same. These all are tendons. So tendons become dark and light, dark and light, but median nerve remains same. Now we will start. We will try to understand through another video in which we will ask the patient to move his fingers so that we can see the tendons moving. Here we can see tendons are moving. So you can see we are at the carpal tunnel and when I toggle my probe, so these structures become hypoechoic and toggling again hypoechoic, hypoechoic, hypoechoic. So the structure above it, which is not showing this change, is median nerve. This is median nerve, median nerve, median nerve, median nerve. This structure is median nerve. Now, area of the median nerve. Normally, the area of the median nerve is less than 8 mm square, but we can find areas ranging from 6 mm to 12 mm square. It depends, but it is always abnormal above 12 mm square. So, what is the advantage of ultrasound? Advantage of ultrasound is that it gives 100% specificity of carpal tunnel if the difference in area is more than 2 mm square, which means that if I take the area of median nerve at forearm and area of median nerve at carpal tunnel and the difference in the area is more than 2 mm square, then the specificity of carpal tunnel syndrome is nearly 100%. So this is the main advantage of ultrasound. These are the two places at which we have to take the area and compare the area. So this is median nerve, where and now I took the area of median nerve here and here. So at both places the area is coming out to be 12 mm square. So there is no change in the area. So if there is no change of the area, then we can determine that carpal tunnel is normal. Okay, this is the median nerve and here this is the median nerve. Now other findings of median nerve is loss of alternate white and dark bands. You can see it is almost all the median nerve is in its entire length it appears dark. So it is due to edema, and on Doppler we can find this vascularity which is normally not present. So we can say that it is hyperemic. So if the median nerve is hyperemic, which means it shows vascularity on nerve and it shows edema, which means it is more hypoechoic than it should be, then these are all additional signs that it is carpal tunnel syndrome. Now, cross-sectional area measurement. Measure the median nerve cross-sectional area at the pisiform level, the most reliable site for CTS assessment. Doppler evaluation, assess for hyperemia within the nerve or surrounding tissue. And there is one more thing that we should do always, that compare the median nerve with the contralateral hand. Means we should always do ultrasound of both hands to reach a perfect diagnosis, and we should also take multiple measurements. So if I am going to take just one measurement of here and here, then the ultrasound will be completed in 1 minute. Even the patient will not feel satisfied. So for our accuracy and for patient satisfaction, what we can do, we can take multiple measurements, and we should always, on the safer side, should always take the measurement of both hands, so we can be more accurate and also can satisfy ourselves and patient also. So this is a study which was done, which shows that in early stages and mid stages, ultrasound is better than nerve conduction studies to determine carpal tunnel syndrome. In 2015, only there was 20% usage of ultrasound in carpal tunnel, and by 2024, approximately 70% usage is the ultrasound is used 70% of the times for ultrasound diagnosis. So the diagnosis through ultrasound of carpal tunnel is increasing. Now these are comparison of MRI and ultrasound. Now we can reserve for special cases. We can reserve MRI for special cases, for undetermined cases, for cases with equivocal findings. Now, different cases. Now this is a case of bifid median nerve, which means that there are two median nerves traveling through carpal tunnel. And why this is important? This is important because there is persistent median artery traveling between two median nerves. And if surgeon is going to operate and he doesn't have the knowledge of bifid median nerve and persistent median artery, then this artery will get injured, which is dangerous. Second, this case is lipoma. This is secondary cause of CTS, and we can see this rounded structure is lipoma, which is compressing median nerve above it. And if we remove lipoma, the carpal tunnel can be resolved. This is another case of lipoma. This is another case of lipoma. The flexor tendons are below the lipoma and median nerve is above the lipoma. There is another lipoma, another case of lipoma, and median nerve is above it. Now this is the case of tenosynovitis. This is median nerve. These are tendons, and there is hypoechoic bands around tendons, which is due to tenosynovitis. In tenosynovitis, there is synovial effusion within the tendon. Hence, the area of the tendon increases along with edema, which compresses the median nerve. So ultrasound is very good for tendinopathies also. There is another case of tenosynovitis. It is an example of ganglion. Dark structure is ganglion. Also the cause of secondary carpal tunnel syndrome. Now this is a case where there is lipoma within the median nerve. Now here there is no use of surgery as such because the lipoma is present itself within the nerve. And we can see nerve is very enlarged, very bright. This is lipoma within the nerve. So it is fibrohematomous lipoma of median nerve. This is the case of MRI in which median nerve is highly enlarged in size, and this is median nerve enlarged in size because it has fibrolipomatous hematoma. Now DDs, mimickers of CTS. Multiple sclerosis, cervical disc disease, brachial plexus neuritis, thoracic outlet syndrome, and peripheral nerve tumors. So whenever the patient is feeling pain and paresthesia in his hand, then always along with CTS, which is very common, we should also rule out these diseases, specifically brachial plexus neuritis, peripheral nerve tumors. So peripheral nerve tumors can also be ruled out by ultrasound easily. Syringomyelia can be ruled out by MRI. Cervical disease, this disease can be ruled out by MRI. And thoracic outlet syndrome can also be ruled out by MRI. Now, but I don't know how to rule out brachial plexus neuritis, but if there is a lot, means considerable neuritis, then it can also be diagnosed on ultrasound. Now, what are the pitfalls of ultrasound? First pitfall is it has high operator dependency. Second pitfall is misidentification of adjacent structures. And third pitfall is variability in measurement techniques. Now, since ultrasound, now these three pitfalls are for every disease and for every radiologist, because ultrasound is heavily radiologist dependent or person performing the ultrasound. So everything is highly operator dependent. Misidentification of structure can always happen in any case, and there is always variability in measurement techniques. So, like I said, we should take multiple measurements. We should take measurements of both hands, and with practice, the diagnosis of carpal tunnel becomes very easy and very fast. Thank you.